Hey guys, I'm Dr. Philip Oubre. I'm in Austin, Texas, and I finally have my little brother on camera. He is also a Dr. Oubre. He's a little Dr. Oubre. And although I think he technically weighs a little more than me. So,
Oh, yeah.
Robert,
You're shorter than me, though, so.
So, Robert, tell me a little bit about who you are and what you do.
Yeah. So I'm Dr. Robert Oubre. I'm an internal medicine board certified hospitalist practicing in Baton Rouge, Louisiana.
Okay, and what hospital are you at in there?
Our Lady of the Lake.
Okay, so
Yeah.
I've recently heard that Louisiana's not doing so good. Y'all are kind of ramping up the cases. And so what's the situation like out there in the hospital?
Well, again, I'm in Baton Rouge, so New Orleans is obviously the one that's really getting hit hard. The presumption is that probably Mardi Gras wasn't good for them in the beginning of this outbreak. It was probably
So
here long
wait,
before
stop.
we.
What is Mardi Gras for the people that don't know what Mardi Gras is?
People don't know what Mardi Gras is.
Yeah.
Mardi Gras is it's a multi-week celebration of lots of parades, big parties, big balls, but parades of people throwing beads, holding beads, and throwing it to people, catching people. People are
Sometimes throwing it
jam-packed.
at people. Mm-hmm.
Yes, but people jam-packed in the neutral ground, just very close quarters. So was probably here by then and spread a lot.
Okay.
I even saw some reports that some other states, Tennessee, Texas, Georgia, whenever they're having their first cases, what they were finding is that those people had been to Mardi Gras in New Orleans.
So is there any increased risk if you were showing your boobies in Mardi Gras that you could have gotten COVID-19? Is that a thing? Or
For the sake of all of us, I'm gonna say yes.
So lesson learned, don't show your boobies during Mardi Gras. So as far as your hospital.
Yeah, so New Orleans is kind of acting as the canary in the coal mine for us right now. You know, we're only, given that they're an hour south of us, you know, we can't assume that we're not going to be in a similar situation as where they are in a few days for a week. So right now we're still okay, but we are starting to see the increase in cases. We're typically are on track for that doubling time every 3 days. So we're right behind them. But right now it's since they did this all before us, we were able to see what they were doing, implement earlier plans and what they were doing, and prepare.
Okay.
As my boss liked to say, be proactive rather than reactive.
Right.
So. Yeah.
So as far as kind of, I assume like most hospital services, you guys tried to do a purge before this whole COVID thing, like people that maybe could have been sent home a little early were sent home early, no questions asked. So what was kind of the capacity when you guys purged and where are you at now?
Yeah, so across the nation, I think most hospitalist services are seeing pretty much we're at 50% of where you are normally. So for us as a group, we normally have 17 doctors there a day. Our census total is usually about 230 to 260 patients a day. For the past
those
week,
17 doctors.
For those 17 doctors, so for every doctor, you're looking at 15 to 17 patients per doctor. For the past week, we've been hanging out about 150, 160. So a little bit higher than 50%, but we purged. But a lot of it happened naturally, I think. So number one, we canceled.
People wanted to get out of the hospital, like, oh my God, the sick people are coming. I'm out of here.
Exactly, which makes you wonder how many people
I'm
we
not
should
so
actually,
sick anymore.
Right, which makes you wonder how many people we should actually be admitting to the hospital in the first place. But so a lot of people just stopped coming to the hospital. Number two, we canceled a lot of the elective surgeries. So all those consults that we're getting, medicine consults for surgeries, those went out the window. So so very quickly got down to 150, 160. But as the COVID cases are starting to come in, you're starting to see that number climb up.
And what about the ICU status? You don't work in the ICU, right?
I don't work in the ICU. I don't work in the ICU, but so I don't know exactly what those guys are doing. I know we did. So the way our hospital is set up right now is that we set up units that are going to be COVID units, and we just have a list of probably 6 or 7 units that you're just going to overflow to. So we had one which was kind of our direct admit unit. So anybody who came in from the clinic or the community, they would land here. It was kind of an extension of our ER. That became our COVID unit. The entire unit was negative pressure. So that's where
How'd
they
you pull
land.
that off?
Apparently, so I don't know if it was negative pressure to begin with, or I heard some rumor that maybe they're installing some vents, but they're massive vents, and there's 2 or 3 of them that are essentially just pulling that much pressure that the entire unit.
So just so people know, a negative pressure room is a common term in medicine, but a
Yeah.
negative pressure room, if you think about it, anytime you open the door, the air exchanges, and so you could possibly spread viral particles out. So a negative pressure room means that if you think about it, my door is right here, and there's a vent in the back sucking air. So as soon as you open that door, air only enters and air cannot get out. And so we use that in communicable diseases. But those rooms are a dime a dozen. I mean, I in my hospital in South Carolina, when I worked in the hospital, there was maybe one per floor, and you had to walk a long ways to go find it. So the fact that you guys were able to convert a whole unit, that's pretty cool.
Yeah. So the whole unit is negative pressure, but even within that unit, I think only a handful of rooms themselves are negative pressure. Um,
Well, anything to
but
decrease the exposure is cool,
yeah,
even if it's not
yeah,
perfect.
right. Um, so, um, but then we have several other units. There's a unit directly across the hall that was our ER observation unit that became overflow, and then a trauma and neurocritical care unit that was also down the hall from that. That was overflow, and we just have unit after unit after unit. Fortunately, our hospital just built a brand new pediatric hospital, so we have much of the hospital that's actually not being used right now. So that kind of worked out in our favor. I forgot how we even got started talking about this. You're asking about the ICU doctor. So the ICU doctors essentially have one ICU doctor covering their the COVID unit, the ventilated COVID unit patients right now, which I'm assuming was probably an additional staff for them. Um, right now, last I heard, we only have about 8 to 10, I think, ventilated. So as those numbers increase, will they
Is
have
that
to
not a
have
lot? That sounds like a lot to me.
I think, I think right now we have about 50 something COVID patients in the COVID unit. So that's either people who have been confirmed or people who are patients under investigation or people who may have COVID. We have tested them. We're waiting for the test to come back. So I think that's a number is around 54 for us today. So that's about 20% of the patients, which is what we're seeing nationally.
Yeah.
So, so are those guys increasing their staffing as we get more and more ventilated patients? I would assume so, but I'm not sure.
So how many open ICU beds do you guys have?
Ooh, that's a good question.
Is that because it's not many, or because you
No,
got plenty of room?
it's a fair amount. I don't know. I mean, I know um, we have our MICU, which is I think is 25 beds. SIU is another 50.
Open? 25 beds open?
Open at this moment.
Yeah, like how many are vacant, ready to be?
Oh, I don't know that number. I know last time right when this was starting, I think we had 100 so odd ventilators, and only 20 to 30 of them are being used. Um, but we're prepared to use PACU, which for those that don't know, it's a post anesthesia care unit. So these are where people go after they've been to surgery. So
Which
those
aren't really
have
happening.
which aren't happening. So all of those are available, and so those have monitors and are ready for continuous pulse ox and all that stuff. So that's all just units that we can utilize.
And so that's great. And do y'all have the staff to cover all that, or the recovery nurses kind of changing jobs and having to learn how to manage all this stuff?
Right. Yeah, that's a good question. Right now, I think it's the ICU nurses that are managing the COVID
There's only a few of
patients.
those. Not that
Obviously,
many.
yeah, and obviously we know across the country those are getting sick. There's been talk of pulling in some of our anesthesia colleagues, our CRNAs who aren't doing much right now, getting them to come in. So I don't know what those plans are. I hope we don't get to where you're hearing in Italy dermatologists are intubating people. I hope we don't get there, but
That's what I was going to ask you next. Is your
yeah.
hospital teaching people how to intubate? Do you already know how to intubate? How
So
sharp are you feeling?
topic is definitely, I've not intubated anybody since med school. So I think all of us as a group do not want to get there. We've talked about the courses and stuff and talked about, hey, should our ICU doctors come and re-educate us on these things? I
Where's the
am
nearest kaleidoscope? Like,
right.
where's the on button
Um,
again?
right. What meds do you give? I mean, there's so many questions, but we're hoping that our anesthesiologists and our CRNAs would step up at that point.
I don't
And
know. It might be time to pick up a book and a lecture and be like, all right, what's
right.
rock you, fentanyl? I don't,
Yeah, which actually this actually brings up a good point. So most of these people we aren't emergently intubating, right? So normally when somebody like me might be put in a situation to intubate is because there's somebody coding on the floor. When we say coding, meaning their heart has stopped and we're trying to resuscitate
they're
them. So
dead. They're dead.
they're dead. Yeah.
And you're trying to bring them back to life. That's what that
Right.
means.
So if somebody's coding on the floor being not in the ICU, that's just a normal hospital bed. Um, if they're coding on the floor, they're dead, and we have to get either an ER physician or ICU doctor to come to there and intubate that person. These people, what we're seeing is they're not decompensating that quickly. This happens typically over the time span of hours to days. So, and the data has shown that if you intubate them early, when I say intubate, I mean putting people on the breathing machine, um, uh, we're intubating them at 5 liters. So
Hold on, you're breaking up.
you hear me?
Yes. Okay. You said
Hello?
you intubate them at 5 liters, and I don't even know what you mean by that.
So people who, if you need supplemental oxygen, you put the little nasal cannula in your nose. Typically, what we start off with is 2 liters. Normally you max out that little nasal cannula at about 6 liters, and there's other step ups from that. So high float nasal cannula and BiPAP, CPAP, these things that other people may have heard of, that we're not doing because we have found that those two things uh, aerosolize the virus even more, therefore spreading it and putting more people at risk. And it kind of delays the inevitable.
So not necessarily worse for the patient, not better for the patient, and worsens all the healthcare workers. So you go straight from nasal cannula to intubation.
Exactly.
Wow. Okay.
So they're intubating them at 5 liters. I've seen some where they sit on the non-rebreather for a little while. Every single one I've seen go on non-rebreather gets intubated anyway. So you kind of delay the inevitable. But
so really, you stick them on the non-rebreather and you call someone to say, this guy's got to be a gal's got to be intubated.
Exactly.
Okay.
So I say all that to say most of these situations are not emergent. You have some time to have an ICU doc or whoever come intubate that person under very controlled circumstances.
So that's what you're seeing on the floor. Is the ER seeing the same thing? People aren't showing up dead. They're showing up with symptoms, and they knew they needed to come in, and they got there in time. Because that's my biggest, as far as practical advice that you can tell people. How do they stay at home long enough in case they have a mild case, and how do they not stay at home too long and show up dead? What's the catch there?
I think shortness of breath is really where.
So here's what's hard for me, Robert, is I so I've got 2 employees out and a couple patients that have been sick. Every one of them have said they got shortness of breath at one point or not. So what's the severity? What do you think you would tell someone? Is it can't stand without shortness of breath, walk a flight of stairs without shortness of breath?
I think so. What we discussed in our meeting the other day was when you feel short of breath walking across your room.
Okay.
So if you go for a 3-mile walk and normally you don't feel short of breath, but now you're kind of feeling short of breath, that's okay.
You made it.
Something my wife and I talked about is that you kind of feel the pressure in your chest right now because everybody's anxious. Just kind of check your internal temperature, make sure it's just not a little anxiety.
Internal temperature, is that a code word for rectal temperature?
I think your breath holding strategy is good. I have, there's these little pulsometers that you can get for $20 on Amazon.
Good luck trying to get one. Oh my goodness.
Really? I hadn't heard that I've heard of people still buying them, but
well, if you can get one, yeah.
Yeah. I think those are great. Right.
Well, okay, so my question on that is, if someone does have that, do you think that will pick it up in time? Because I always worry people are retaining more CO2 and having issues getting the CO2 out and feeling short of breath, but their oxygen sats are fine. You're not seeing that?
Not that I know. I haven't. We from again. So just to update your audience, I haven't. I've seen one. I've personally taken care of one coronavirus patient. But obviously, I'm talking to a lot of my colleagues, and I've seen some of the charts of these people. But I'm not seeing much. I think from what we've seen, we haven't seen much hypercapnia, or what you're asking about is elevated carbon dioxide levels. Actually, what we're seeing is the opposite. Is these people are breathing quickly in order to make up for their lungs being damaged and exchange more oxygen. So they're breathing quickly. So actually the carbon dioxide levels are actually lower whenever they're coming in.
Okay. So I'll be interested to know as that goes on, as you start doing ABGs and PVGs, is that really what you're seeing? Are you seeing hypocapnia? Are you actually seeing hypercapnia? Because that's one of my big concerns is people are looking at their oxygen sat saying, hey, it's perfectly fine. I don't need to go to the hospital, and then showing up dead.
Maybe for the COPD people out there, I might worry about that. For the general population, probably not. But I think a pulse ox would be helpful because some cases I've heard of is their presenting symptom was they were delirious at home, acting weird. And I know fever can cause you to be delirious, but I think in those situations it's because they're hypoxic.
Yeah,
they didn't have any oxygen going to their brain, so they're acting weird. And
that is a great point, Robert. I think too many people miss that. Just because you're not blue doesn't mean you don't have enough oxygen. Mm-hmm. And delirium is delirium and anxiety are two definite symptoms of low oxygen. If you put a bag over your head and you can't breathe, I guarantee you're going to be anxious in a certain amount of time. At one point, you're going to kick into anxiety. So yeah. Not enough oxygen definitely makes you anxious, but you should be breathing pretty heavy by that point also. Okay.
Right.
Oh, that's a good topic.
So I think we have, to answer your question, I think we have had some dead on arrival. I don't know the numbers. Most of those situations I'm hearing are people that were at home by themselves, had nobody checking up, nobody heard from them for 3 days, and so they called for a wellness check from the fire department, stuff like that. So, I had a buddy that seemed like he was probably going to have COVID. So I was like, hey man, I knew he lived alone. And I was telling him, hey man, make sure you're talking to somebody 3 times a day. Make sure, so that if you start acting funny over the phone or they don't hear from you, they know to, so I think those have been most of the cases.
I'm hopeful that if we spread this word that the breath holding thing can work, if people are seeing that breath hold decrease, and for those of you who don't know, it's just you hold your breath as long as you can, and you record that number, and if it's dropping, it says that your lung capacity is running out, time to get seen by someone. I think that can help people analyze their breathing and not lie about it. So tell us of a couple cases that you've seen, Robert, and I know you've only had one, but what are you seeing? What are your colleagues seeing? Or I think my biggest question, and I'm sure everyone else is wondering, is, are healthy people dying? Are they getting hospitalized? Mm-hmm. Or if they're like, what are you actually seeing as far as people that get hospitalized and who gets intubated?
Yeah, I think we're probably seeing again. We're still very early on in this infection for our hospital for Baton Rouge. So, but from the kind of the early patients, I think we're seeing what most of the rest of the country is seeing, that by and large, healthy people. So healthy people, you're going to get this virus likely. But I think in one article I saw that the mortality rate for healthy people is about 1%. So we have had, I know of, now for comparison, risk factors such as cardiovascular disease is about 13%, diabetes, uncontrolled diabetes, underlying lung disease, that's about 8%, for some context there. So far less.
Are you seeing diabetes by itself? Is that a significant risk factor? Are we talking about the typical diabetic, the trilogy of diabetes, high blood pressure, high cholesterol, obesity, cardiovascular disease? Are we just talking about a 40-year-old diabetic?
Well, being in Louisiana, rarely do we see it by itself. So I don't know if I can answer that one. So usually in Louisiana, we have the trifecta of obesity, diabetes, hypertension, smoking, all that stuff. So I don't know if I can answer that one for you.
Has anyone young and healthy, meaning let's say below 60, has anyone below 60 without any comorbidities gotten sick died intubated?
Uh, Unfortunately, we have seen. I know of one case that presented to the hospital, to our hospital. Lower 50s, no known past medical history. I think it was mentioned that she had not seen a doctor in so many years. So did she have secretly underlying uncontrolled high blood pressure or diabetes? Who knows? But seems like no past medical history. But she actually made herself a DNI on presentation. So do not intubate on presentation. So that was her choice. We had to respect it. So she unfortunately, I think, did succumb to her illness within 24 hours. But with no underlying medical problems, she would be the person that I would have expected to maybe go on the ventilator, may have to be on the ventilator for a week or two, but probably would have survived this.
So that was one of the first things on my bullet point that I haven't gotten to ask you is I want to know all about code status, or at least I want to have this discussion because in general, not just in America, no one wants to have this discussion with their loved ones as far as code status. So when we say code status, it means, do you want us to do CPR if your heart stops beating? And what most people don't realize is CPR is not like you see in the movies. There are needles involved. There are ribs breaking involved. There's chaos. There are no loved ones in the room. And it is a terrible way to die, to say it plainly, because it is not pleasant. Now, luckily, when someone their heart is stopped, usually they're not awake, so they won't remember it, but it's not the way to exit this planet. The other code status is DNI, or do not intubate. There's various levels and stuff. We're going to boil it down to those two. And so do not intubate says that your heart is still breathing, but you can't keep up with your heart is still beating, but you're not breathing. So we're going to put a tube down your windpipe and breathe for you. Now, in many situations in the hospital, we're encouraging people to be DNR and DNI, and that's because you're elderly and you're very sick, and your chances of living through your heart stopping or lungs not breathing are slim to none anyway, and we're just going to torture you, so you should be DNR, DNI to have a peaceful death. There's a good article, if you're curious, to look up. It's called How Doctors Die, and it's a good article that's written that we can do some great things in medicine, and we can do some awfully terrible, torturing things to human beings in the name of medicine. And it doesn't give you any quality of life, and it's torturing, and it's expensive and all that. So we respect when people want to be DNR, DNI, but there is a time for intubation and ventilators. And for people that have a good chance of coming out without any neurological deficits, meaning your brain comes out intact, right? Nobody wants to be tubed and wake up a vegetable. That's not what we're going for. But in this situation of this COVID-19, if you're healthy enough to fight the virus, we just need to ventilate you and give you that support while the virus is running rampant through your lungs. So, Robert, what's kind of the discussion you're having with people as far as code status, and what are you recommending?
Yeah, that was a great summary. But so we're getting our
I
palliative
hear
care.
baby Benjamin in the
Oh
background.
gosh. uh,
That's all right. Baby's crying.
So we're getting our palliative care colleagues on very soon. So which palliative care is our end of life doctors who are skilled at having those kind of discussions and but getting them involved very quickly. So, but yeah, I think having those discussions with them early so that whenever you're still awake and can have that decision, because I think there's for a lot of people, and I wanted to mention while you were saying that, I wanted to mention that, you mentioned that this is not like what you see in the movies. Whenever I was in residency, there was a guy who did a study on the success of CPR in movies, and he saw it to be 80%.
Oh, wow.
Of people in the movies who got CPR that
Miraculous.
walked out of the hospital. In hospital CPR, the chances of somebody getting CPR and walking out of the hospital is less than 1%. Yeah, so not what you see in the movies at all. So I think the making sure that while patients are still awake and can have that discussion to take the pressure off their family members of saying, yeah, if it looks like I'm not going to recover, if it, if you're just, I think, but to really boil it down to, I think maybe what some people are starting to hear in the news, because we actually had some ICU nurses that were hearing this and came very concerned to us, was that, hey, I hear y'all aren't coding these patients. And I think there may be some rumors of that in the news as well. And we want to first and foremost say that's not true. We are coding these patients, and whenever so
And when you say
they're
coding, you mean performing
code
life-saving measures.
exactly. So um, going back to what we are talking earlier, so if your heart stops, we resuscitate you by, number one, putting you on a breathing tube. If this happens normally in the hospital, we put you on a breathing tube. That is being done for these patients. If your blood pressure drops, so in a code, if your heart stops, we give you epinephrine, uh, which is adrenaline. So we give you epinephrine for these patients who their blood pressures are dropping. We're giving them epinephrine. We're giving them norepinephrine. We're giving them pressors to bring their blood pressure back up.
Mhm.
What there's some discussion where this rumor is originating from is that there is being determined that chest compressions, which is kind of the last step in that process, may be futile. And it makes sense if you think about it, because the
Yeah.
whole point of chest compressions is to circulate blood from the heart into the lungs back to the heart. In this situation from COVID, your lungs are not circulating oxygen. So there is going to be no oxygen to be circulated to be brought back to your heart. So it's just going to cause you a lot of pain
So
and for
basically, if
no
your lungs
benefit.
fail, but your heart's still beating, and then your heart
Right.
fails, by that point, there's no point because the heart
Exactly.
failed, the heart stopped because the lungs are already stopped, meaning you can
Exactly.
do compressions, but you're just wasting doctors' times, money, all that. Well,
Right.
I think
Right.
there's some practical advice here. So I think the number one thing that comes out of this conversation is go have that uncomfortable conversation with your loved one. Say, I love you, but how do you want to die? What do you want your last moments to be like? And
Mm-hmm.
what I want to stress to everyone is, although this COVID situation, see on the news and all that, it sounds like a terrible way to die. It's not. If you're an
No.
elderly person and you are sick, getting sick and falling asleep with poor oxygenation is actually quite peaceful. So you
Mm-hmm.
may see that person breathing heavy or coughing or something like that, but usually by that moment, they've built up so much CO2, as Dr. Oubre already said, hypercapnia. You've built up so much CO2 in your bloodstream that you go into what we call CO2 narcosis. And that means you're just sleeping, right? Narcosis means you just fall asleep. So you're actually asleep when you're slipping into low oxygen status and dying. So I do want to encourage people that if you're having that discussion of DNI and DNR, do not intubate, do not resuscitate with your loved one, that remember, it's how do you want you to die is very important. Do you want a peaceful death surrounded by your loved ones and trees and sunshine and all that? Or do you want to be in a hospital surrounded by 10 loving healthcare practitioners, but that are pounding on your chest and injecting you with things and fluids and all this? That's not how I want to go. Now, if I'm young and healthy, so if I do in fact go down with COVID, another lung infection, whatnot, I will get intubated because there's a very good chance that I will come back alive. But for grandma, grandpa above 80 who have comorbidities, it might be the right time to have that discussion and sign the papers.
And another practical point that I'm sure it's kind of spread around as well is that a lot of hospitals aren't allowing visitors. No visitor policies. The one exception is for dying patients. So if you have that conversation early on, it's well known that, hey, okay, once we do this, this, and that, we'll start switching to being more comfortable. Once you get there, everybody can be on the same board. Okay, this person is dying. Let's bring in family. If you don't have that understanding, then you unfortunately die in an semi-emergent situation, and no family is able to be at bedside. So I think that's
What sounds even
important to
worse
know.
than that, Robert, is if there's no visitors and it's like not like that's going to end anytime soon. Let's say you do intubate that person and they survive for 7 days. That means they've been in a hospital for 7 days and not a single family member came by to squeeze their hand, kiss them on the forehead, or
Right.
whatnot. That made me emotional. Uh,
Yeah.
that's hard. So have that
Yeah.
discussion with your loved ones and really think about them having a peaceful death at home before bringing them into the hospital and making them suffer.
Yeah.
Anyway, let's switch off of that dark topic. So and on that note, I actually want to kind of pause the video and start a new video because I want to talk all about this cardiovascular thing.
Mhm.
This virus can affect your heart. You're the only one in my kind of realm of people that are talking about this. So let's end the
Hmm.
roll here, and I'll introduce you again, and we'll bring it up. Okay.